Next, I'd like to invite Dr. GAURAV LUTHRA from Dehradun. And Gaurav is very, very well.
So at the outset, I would like to thank Dr. Cyrus for including me in his course. And for those of you who don't know, what Cyrus has achieved in the last year or two is something great. So going on, this was a patient who was, post vitrectomy, and challenging one because it was totally subluxated and there was a lot of phacodonesis. Fellow eye was lost to previous multiple retina surgeries almost 10 years back. So this was the only eye of the patient, and he went from 618 to 3 by 60 and then decided to get operated. It turned a brown cataract in this time, and being a vitrectomized eye, we were anticipating all the issues that you can. So and had significant astigmatism, so my threshold for using toric lenses is low. Nothing wrong in doing the toric lens if the bag was intact, so we decided to go with a planned toric IOL, except that the capsule was very friable. We could do the rexis. I would have liked a bigger rexis, but we could just about get a 5mm smaller, about a 4mm rexis, because we didn't want to kind of take a lot of risk with the bag which was moving around so much. It was obviously a very, very hard cataract, but even with a small rexis, staying in the central A zone, we could manage with gradually getting everything out. And of course, using the capsular hooks for stabilizing the bag, because the bag was quite mobile, and being a one-eyed patient, we didn't want to take any risks whatsoever. So at the end of this process, we were left with a bag which was very friable, had lots of plaques, and I'm sorry, what happened to that? Had lots of plaques, and we set about trying to get those plaques out. And obviously since they were nicely stuck doing the cortex extraction, we had to keep trying to polish it and peel those plaques, and it was a little tough because you could increase the dehiscence at any point. You could break the PC. It was an eye which had previously held silicone oil, so the capsule was very peculiar as well. So painstakingly, and this is all edited, so painstakingly we managed to clear one quadrant, and then I realized that I have to change tack, and I went in. So these are special bimanual handpieces that I'm using. These are both sandblasted, and they are matched to my incision. So I decided that I'll go with a technique which I call as the jet polish. So for this, you need to go from the main port because it doesn't work from the side ports. You go in from the main port, keep the posterior lip depressed. So that sets up a very high flow system. And using the irrigation handpiece, you can go and do a jet wash, which basically sets up a very fast flow fluid. And then here we've changed hands. So initially I did that one quadrant where it was possible to do it from the main port. Now since I have to do it on the other side and I want to switch hands, so what I'm doing is I'm running now the infusion from the side port, but I'm opening the main port with another instrument so that it still sets up a high flow process. And now I'm going and doing the same thing in all the 360-degree areas of the equator of the bag, loosening up everything, because then it'll make it very easy for me to aspirate. Now just watch how I aspirate. I was struggling to clear that up initially, and now everything is so nicely loosened up. I call this as the jet polish or the jet wash, and it works extremely well to clear up all these resistant plaques and all that sticks to the bag, and very sticky cortex or stuff which is not ready to go, except for plaques like the one which is right in the center, which requires to be peeled. So now this plaque, my only hope is to peel it or maybe do a small rexis in the center, because can't leave it there. So I try to take it off very gently, and then changing hands and changing forces, making sure that, because this capsule, as we all understand, is very, very friable and easily breaks. So you have to ensure that neither are you putting in a lot of viscoelastic nor less. You don't want any kind of damage to the capsule there. So we managed to, by pulling in several different directions, and since all this is edited, so you can understand that would have been more painstaking than what is evident here. and finally I was able to get it off. And I was very happy that, now I'll have a great outcome. I'll go ahead, put in a toric lens, and now I was a bit relaxed. So, it's almost like paradise regained. But you can see that the rexus is really small. And now, okay, for a moment I think, oh God, sorry. That was a nightmare. I thought all the cortex came back. So, so now that little bit left, and see what I've done. I've broken the rexus there. So let me just take you back. What I was trying to do was, I was just lazy. I was using my right hand and thinking that I can get that cortex out. Went a little too far. And after all that effort, I managed to break the rexus with my cortex removal, by manual. So anyway, now I'm in a situation, because now it'll be tough to put in a toric IOL and let it remain well centered. So I changed the lens. I now go in with a regular single piece lens, which will hopefully remain in the bag. And we ended up managing this case fairly well. Patient did well. The astigmatism was about 2 diopters, so it was not so bad. But eventually, the lessons were all learnt. The cortex that can be removed like that, what I showed you, and then of course not being lazy. And this is my favorite trypan blue test for any leaks, and that helps me check for any micro leaks and all. And so this was one new way of using these devices. So now this is another case where a patient came with trauma to our hospital and was operated by a cornea surgeon for a perforation, and went on to develop a traumatic cataract. This was the perforation repair which was done, and there was, after that, patient went on to develop over a period of time significant traumatic cataract, a rosette cataract. Also would require surgery, and the problem was the big iris defect. So we had to manage this as well. We thought of doing single pass 4-throw pupilloplasty kind of a thing, but frankly, there was almost no iris tissue here, almost 2.5 clock hours missing, and even this was not enough for me to fashion a pupil, and the defect size was so huge. So we started about looking for prosthesis which could something which could block this area. Patient was symptomatic with all the glare and everything. So while doing the cataract, we also noticed significant astigmatism, so we decided to correct it with a toric IOL, and it was symmetric bow tie. So we went about several designs, and finally settled with a design which was in fact, this was one of the prototypes which was supplied to us earlier. We also got one which was about 2/3 of this. So we finally settled with something which was about 2/3. We got this, kind of lesser than this, because this would have been very difficult to insert as well and manipulate inside. So finally went with this, and the cataract surgery was mostly straightforward. Not much to the cataract surgery. And once the cataract was out, we could then put in a toric IOL, position it, and then the process of seeing. So I think, okay, so we went with the same ring, and that's why that one is shown there. I'd forgotten. We had got 3-4 designs made. In fact, we had kept aniridia rings as well, which come in pairs, because we were not sure that this is going to stay. So after 3 or 4 trials, and this is the final trial where we managed to, we also thought whether we should be putting this in the bag, but there was no way it was going to go into the bag. It was very bulky. So this had to be positioned in the sulcus, and because there were some iris issues here, we finally managed to get it behind the iris. But cosmetically, it came out really good. Patient did really well subsequently, and this is how, so this is the segment which is kind of covering everything, and this is the toric alignment, and the optic edge is nicely covered. So patient went on to do well, and the astigmatism correction came out so beautifully that patient was 6'9", unaided, and there was almost no residual astigmatism, and eventually accepted about this much and did well. So this was one case. If I have time, Cyrus, can I show one?
Yeah, go ahead.
Okay. So this was customized with Care Group, and they worked very hard. They were quite supportive because they gave 3-4 designs. The only thing is that I want to see long term. This is about a year old. How long the pigment lasts. That's probably the only issue which everybody thinks may or may not work. But I do have several patients with the aniridia ring, which also from Care Group, almost more than 15 years old. They somehow have still held their pigment. So, and I have no financial interest with them, but they are supportive in these areas. So a BHEX, I don't know, has somebody shown a BHEX yet, Cyrus?
No.
So I thought, because I removed my Malugin slides, although my favorite is also the Malugins, but I thought I have to do justice to BHEX. as well. It works very well in certain situations if the pupil is not very small, very rigid. Otherwise, you'll have to do a stretch. It's a very nimble, nice ring. Only thing is you have to learn how to kind of ensure that it goes in. Yes, it is difficult and challenging in certain situations where the pupil is very small or too tight. Then, it becomes a challenge to insert it and even to remove it sometimes. Removing it from the pupil is sometimes a challenge. Removing it from the eye is very, very straightforward. You just have to hold it and it pull out and it comes out. So what Suven actually tells us that to use the forceps, and I agree with him totally now. This is one of the slightly older videos. But today I would also use the forceps which come with the B-hex. That makes it much easier because you just have to go from 3 areas and then hold it from one of the central eyelids and then push it under the iris at 3 points. It holds quite well. The only thing is that you don't get a huge pupil size. I mean, with the Malugins, which I find much easier to use and slightly more challenging to remove from the eye, you can get maybe a slightly bigger pupil size than what you get with the B-hex. So all the same, the price is almost 1/8 or I don't know 1/5, but it works well, and you can then complete your surgery. Bringing it out, as I said, is quite straightforward. If you're not careful, sometimes the B-hex will dislodge and go behind the iris. Then it becomes a little bit of a challenge. But otherwise, if you're careful enough to remove it gently and make sure that it remains anterior to the iris, and very rarely you can see how it catches onto the iris as well and shreds it. So then bringing it out is fairly straightforward, and you can see that it comes out and very nicely from even a side port. So let me finish by showing you a disaster from the Malugins ring, which one of my friends shared with me for my course, which is the Lord of the Rings in the SCRS. And this gentleman is practicing in the UK, and he is also a fan of the Malugins ring. He was after finishing off with the surgery, he decided to remove the Malugins, and as you can see, as he's trying, it's a very atrophic kind of iris. Harshul, this is for you. So very atrophic iris. He is trying to dislodge the Malugins ring, and it's tending to, sometimes it tends to trap the iris tissue, and especially it can get wrangled on it, and 99% of the times it doesn't matter. But now he's got 3 rings off, the 3 twirls off, and then he decides that he got the 4th one. He manages to now use the injector to remove this. And now you can use this injector to go from a 2 millimeter incision, and that's the good thing about it. So you have to just go from the side port and catch it. So in this department, I think the B-hex is much simpler. You just have to hold it and pull it out. But once you get used to using this, it also works. And Harshul uses a very nice...
you just use the inverted Kuglin
yes,
stroke. Yeah,
yes.
Most of the time I use that.
No, even to inject, you use that cartridge, right?
Yeah.
Now once you catch on to it, which can, as I said, can be tedious, and I'm hoping this video moves forward faster. Maybe this is not the edited version which I thought I'm showing, but anyway.
Slow motion,
yeah, I don't know.
Slow
it
motion
seems to have got
fake.
stuck there for some reason. Anyway, he catches it finally. Then, of course, as we all know, how sometimes it will just get entangled. Then you just push it back, and see, now he's made a mistake.
Yeah, it was.
Yeah, so that's why I'm showing this, because if you make that mistake, then this is what you have to deal with. Now, with that mistake, it has twisted and it has caught the iris. That's what I remember. Now it's caught the iris, and now it's going to...
Because his attention is only
on the thing,
on that
right?
nozzle,
So these things you have to be careful about, and see, now it's a total mess. So anyway, so finally I think he was able to free it, but not before traumatizing the iris completely. And so I think all the devices are great if you know how to use them and know how not to make complications with them. And but in general, I think the Malugins is one of the safest expander devices that I've used as well. So I'll stop here.
Gaurav, I want to ask, that first case, there was like a subluxation.
Mm-hmm.
There was like a overall generalized ulnar weakness. put a lens in the bag. So, wouldn't you think that that bag would need support?
So, there was donosis, all right. It was a vitrectomized eye, so there was no vitreous support as well. But, the other option was to have just removed the bag and gone with a glue dial or something, right? But I felt that there was enough support at that time. I had planned to put in a CTR, but because now my rexus was broken, so a CTR was not going to be possible. So then I just decided to go with that thing because I had meticulously cleaned the capsule and didn't want to feel like sacrificing it. But yes, if I think about the future, I should have probably put in a 3-piece lens, number one, because I could then later on use that to, you can use it to kind of anchor it to the sclera if you need to. And only problem is that by this time at the end of surgery, my thought process was probably, after you work so hard and you clean up everything, but in retrospect, I think I should have put in a 3-piece. That would have been the wiser thing to do rather than put a single piece lens, or even take away the bag and do a glue dial kind of a thing.
So if this happens and your rexus is torn, has anybody put an endocapsule ring after this?
So some people have shown it, but I personally don't like to do it because it can extend. Either use a smaller ring, which doesn't work, which has no meaning. If you put an adequately sized ring, it's supposed to stretch the equator of the bag, and if it is doing that, it will just extend the break in the rexus, and it will just kind of go behind possibly, and you might even have a ring which is, which drops. So I don't see any point in putting a ring once you have a broken rexus of this kind.
All right. Thanks very much, Gaurav. Since you are the leader of the hooks and rings, I thought that you could really do justice to this topic.